I have the privilege of talking about some of my own work. I'd like to talk to you about two research fronts related to emerging treatments for lymphedema. I understand the subtext of this meeting is primarily breast cancer. The first project I'll be talking about is actually more of a universal approach to lymphedema, both primary and secondary, both arm and leg, but I will also be talking about some breast cancer specific work in the second project. So this cartoon really does not illustrate the current status of lymphedema. I don't think anybody would be challenged to think that this is a hip disease yet, but I think part of the problem it hasn't been hip is that we haven't had fully cohesive interventions for lymphedema. Physicians have not historically been interested in treating this, as Sumner Slavin so beautifully illustrated in his introductory remarks. But I think that some of these newer strategies, I hope, will bring it a little bit more into the hip arena. So the first project that I'd like to talk to you about is the role of inflammation in lymphedema and the promise of drug therapy for lymphedema by specifically targeting this inflammation. So I became challenged by the question now 15 or 18 years ago about why this early phase of lymphedema, when the condition is characterized by pitting, will progress to this irreversible phase where we have tremendous structural alteration in the tissues that seems to be relatively unique to lymphedema. We've always had wonderful physical interventions to deal with the hydrostatic phase of lymphedema, but really precious little for this phase of the problem, which has been deemed the irreversible component of lymphedema that everybody dreads so much. So actually, very early in my work, I made a pilgrimage to Sumner Slavin and asked about the animal model that he touched on briefly, and that's one that we have continued to modify and use in our work, a high throughput model that allows us to study the biology and also to have interventions to try to change the outcome. We have evolved methodology to actually quantitate the volume of the mouse tail that is induced to develop lymphedema, and we're able to harvest tissues and to undertake molecular analysis. And my initial thought was, why don't we look at the difference between lymphodematous skin and normal skin and try to understand not what's happening in the vessels, but what is happening in the end organ, which is the skin. How is it responding to this lymphodematous state in order to understand what the pathways may be that will allow for an intervention? And what we were very pleased and surprised to find is that the vast preponderance of the molecular expression profile in lymphedema is related to inflammation and to immune function within the skin, and very little to any of the other components that might be of interest. But this gave us a focus and a pathway to follow. So in our naive conception of lymphedema, we think that the dysfunction in the vessels concurrently lead both to the development of interstitial edema as well as to the immune dysfunction that is inherent there and that leads to some of the predisposition to soft tissue infection. And this, with the subsequent chronic inflammation, will lead to the progressive fibrosis and adipose deposition that characterizes the late stage of the disease. Well, we, through our molecular analysis, decided to focus on this function of chronic inflammation. And we were very interested to find that within that profile that we uncovered, there was a signal that we didn't anticipate, which is a pathway headed by an enzyme called 5-lipoxygenase, or 5-LO. This is the parent enzyme that leads to the generation of a group of inflammatory mediators called leukotrienes, which are known to be important to the process of inflammation, but in medicine up to this point have been chiefly a target when related to airway disease. So some of you may know of the drug Singulair or montelukast, which is used to suppress these leukotrienes in the airway. But we were surprised to find that there was a signal related to lymphedema as well. And this led us to semi-empirically choose an agent to look at in the murine model of lymphedema. The solid red line that you see here represents what all of the nonsteroidal anti-inflammatory drugs are capable of doing, which is to block cyclooxygenase, which in turn blocks the inflammatory prostaglandins that create anything from joint pain to headache to muscle ache. But there is one closely related drug to this one, also in the NSAID family, called Ketoprofen, that in addition to blocking cyclooxygenase, also blocks the 5-LO pathway that I just alluded to. Okay, so this is the enzyme that we found expressed in our skin tissue, and we decided to use this drug because we would not only get the benefit of cyclooxygenase inhibition, a more generic form of anti-inflammatory effect, but specifically block 5-LO. And what we found, again, much to our delight, is that when we looked at the skin histologically, we saw not only reduction in the edema volume, basically to normal over a period of about 2 weeks, but actually found that the skin architecture reverted to normal over that same period of time. So addressing the so-called structural irreversibility of the disease. And furthermore, when we looked at the lymphatic vessels in the specimens by specific immunohistochemical staining, what we see in untreated lymphedema is what I call positive microvascular remodeling. These vessels engorge and enlarge in size and number to accommodate the interstitial fluid that is not draining properly. And of course, these vessels are not typically seen in normal skin. They're typically compressed and contain very little fluid. Over that same period of about 14 days, we found that these vessels would compress and revert to normal as well. So this was very encouraging. We felt that this represented a positive therapeutic response. And then we began to ask ourselves, well, all right, is this an NSAID effect? Does the lipoxygenase have nothing to do with this? Or is that really the important component? And what we found is that whenever we used a drug, and we tried a variety of them, that would block 5-lipoxygenase, we would get a positive therapeutic response. But when we used a drug like ibuprofen, which closely resembles ketoprofen but lacks that 5-LO property, we in fact didn't see any therapeutic benefit, and often the tails looked much worse than they did in the untreated state. So we looked at these variety of drugs and basically found that in order to get a therapeutic benefit, we had to block something in the 5-LO pathway, and the cyclooxygenase component seemed to be, in fact, completely irrelevant. So going back to this pharmacologic model that we started with, it became clear that we really were not interested in the right-hand part of the equation, and that we're very interested in this pathway. Now, 5-LO, which produces leukotrienes, actually produces a whole family of leukotrienes, and we were interested then to find out, is there a specific one of these that is actually the operative agent? And it turns out through a variety of lines of investigation that LTB4, which is one of these downstream leukotrienes, in fact, is the operative agent that seems to be playing a role in the pathogenesis of lymphedema. We went back and looked at sera derived from the mouse model, both normal and lymphedema induced, and we also were able to harvest samples from healthy controls as well as patients with a variety of types of lymphedema. And we found that both in the mouse model and in human, the disease is associated with markedly elevated levels of LTB4. This molecule poses a lot of interesting possibilities, because what is known in human biology is that, in fact, when LTB4 stimulates its obligate receptor, there are a variety of disease states that can arise. And of course, it becomes very interesting to think about obesity, insulin resistance, and atherosclerosis, specifically because of that still as yet poorly understood communication pathway between the lymphatic network and the adipose biology that becomes abnormal. So LTB4 may actually be playing a role in that as well. We subsequently did work with a very specific antagonist of LTB4 to try to see if we could replicate the Ketoprofen findings and or create something new. And here you can see the equivalent of a lymphoscintigram in the mouse tail. So in the normal, you see this nice hexagonal arrangement of these lymphatic microvessels in the skin as they arrange themselves around the scales in the skin. With the advent of lymphedema, basically everything becomes disorganized. This is the equivalent of dermal backflow, just basically disruption of uptake of the interstitial fluid into the lymphatics. And again, in as little as 7 days after giving this systemic drug that blocks LTB4, we see almost complete restoration of the lymphatic anatomic network and presumably its functional integrity as well. If I can make this work, I will show you what an indocyanine green imaging study looks like. Well, maybe it's not going to work. Sorry, you'll have to take my word for it. When we give bistatin, we see that flow through the draining large collectors from the tail into the body of the mouse are restored, which is not the case when we treat with saline. There's basically no movement of the indocyanine green from the tail into the major vessels that are going to progress up to the heart. So in summary, what we found in the preclinical model is that when we specifically antagonized LTB4, we reverse edema, we improve lymphatic function, and we restore the lymphatic architecture in the mouse tail model. We do need low levels of LTB4 for lymphatic repair, but at higher levels, we have uncovered the pathways that are presumably important in blocking lymphatic regeneration. Well, all of that concurrently, as we were trying to understand what Ketoprofen was doing, we were very aware of the fact that Ketoprofen is an approved drug for use in the United States as an anti-inflammatory. And because we had such strong evidence of its utility in the mouse, we decided to launch a series of human clinical trials. And some of you may know we just published this work, which really has taken many, many years to complete. It was just published a couple of weeks ago in JCI Insight. So basically, as we progressed from the mouse model to the human model, we became very intrigued to replicate what we were able to look at under the microscope, which was this restoration of anatomic integrity by reducing the thickness of the skin under the microscope. And we decided to measure that as a clinical endpoint by looking at caliper skin thickness. So this is a typical patient in our trial, in the open label portion of the trial. This is a breast cancer survivor who prior to treatment had skin thickness of about 35 millimeters. Normal would be 1 or 2 perhaps to be picked up by the caliper. This is equivalent of the Stemmer sign basically. And after 4 months of exposure to systemic Ketoprofen at standard dose, her skin thickness had reverted to about 3 or 4 millimeters, so just barely above normal. When we look at that endpoint in aggregate, we found that, in fact, virtually every patient in the open label study responded favorably with a very substantial reduction in skin thickness. And we also did cutaneous punch biopsies and used an empirically derived histology score based upon 4 variables, and again saw this dramatic improvement from the baseline abnormality as we saw the inflammation resolve, dermal epidermal thickness return toward normal, reduction in collagen content of the skin, and so on. Because we had already determined that we were interested in 5-LO, we also wanted to look at 5-LO expression. What's happening? 5-LO expression within the skin biopsies, and we specifically stained for 5-LO activity both within neutrophils and macrophages. And not surprisingly, because we know the drug does reduce 5-LO expression, we saw the appropriate reduction in the expression of the molecule in these inflammatory cells, somewhat confirmatory evidence that we were looking at the same phenomenon. So this, of course, brings tremendous hope. Ketoprofen is not a perfect drug. As many of you know, the NSAIDs do have black box warnings regarding cardiovascular potential toxicity. So as I start my patients on this medication, we have a very extended conversation about risk-benefit. We monitor renal function. We monitor for a pre-existing cardiovascular risk, but we do have a drug now that is available to use in real time as we continue our work in looking at LTB4 antagonism. Some of you may know that we have been studying this in a subsequent trial, specific LTB4 antagonist called Ubenimex. We are still analyzing that data and are continuing to move forward to develop perhaps a more perfect drug. But that is what the ULTRA trial was, and hopefully we'll have some information to divulge in the coming months. I'd like to move on briefly to another project, which is improving surgical outcomes and leading ultimately to lymphedema preventive strategies. Dr. Boyages talked about the fact that in his program, for example, with autologous lymph node transplant, there's about a 50% response rate, which on the one hand is very encouraging, but on the other hand, we'd like to understand what happens to the other 50%, and can this be made into a more perfect surgery? We understand from animal models that the rate-limiting step in vascularized lymph node transfer is, in fact, the engraftment of the lymph node into the surrounding lymphatic circulation. And to that end, we have developed a device to be used at the time of surgery that we believe will facilitate the engraftment of the lymph node. We call it the BioBridge, and it basically is a filament derived or created from normal mammalian collagen with all of the antigenic components removed, and in a post-processing, the fibrils of the collagen are aligned uniquely in a single direction to give us a cross-sectional appearance that looks like this, that turns out to be a very propitious environment for the growth of lymphatic endothelial cells. So when you take human lymphatic endothelial cells and grow them in tissue culture on these scaffolds, they align themselves in an extraordinarily anatomic and functional manner, suggesting that they are healthy and thriving. Well, based upon those observations, we took this to a large animal model of lymphedema with lymphadenectomy and radiation therapy. You can see the radiation port here in the hind limb of a pig, and this is the model in which we demonstrated that not only did installation of these biobridges reverse the lymphedema, but we also were able to demonstrate new growth of lymphatic collectors in proximity to the fibrils of the BioBridge. I should note that this BioBridge, while completely biologically inert, is in fact resorbed over a period of 6 to 9 months after its surgical implantation. It's basically put into the field in apposition to the transplanted lymph node. When we look immunohistochemically, we can in fact assert that these are lymphatic collectors because they stain both for lymphatic endothelial cells and for the smooth muscle cells that Dr. Pedera talked about earlier today. Based on these observations, the FDA has granted me an IDE to study the BioBridge in humans, and we have funding from the National Cancer Institute to perform a multi-site study in order to determine the aggregate effect of use of the BioBridge when combined with standard vascularized lymph node transfer techniques. This is a schematic of what's accomplished. The lymph node is placed with approximately 5 of these scaffolds placed afferent to the lymph node and another 5 efferent to the lymph node to facilitate growth of both the afferent and efferent lymphatics into the node itself. We'll be studying adult patients. They are breast cancer survivors at least 3 years beyond completion of treatment because the FDA is very concerned that we demonstrate that there is no implication to the cancer diagnosis by the use of these biobridges. They may have to have involvement at one limb only, and they have to be eligible, obviously, for surgical intervention, and they have to have completed standard manual therapies for lymphedema prior to inclusion. This is our patient 0, who is actually 1 year out already from the surgery, and you can see that she, in fact, she did receive the BioBridge, and she had actually an excellent clinical response. Perhaps of greater excitement to me is the fact that we can now think about this same device to be used in a preventive application. So now we have gone to the rat hind limb model, and we are performing a similar intervention of lymphadenectomy and radiation therapy. But in this case, we are placing the biobridges across the site of surgical intervention at the time of the lymphadenectomy. These biobridges are not they're radio-resistant. So basically, we can go on and do the radiation therapy and not lose their structural integrity. And we can calculate volume by a CT, micro-CT approach. But the basic thing I want to show you is that when we use the biobridges preemptively at the time of breast cancer intervention, we see this dramatic collateralization of lymph node drainage to the contralateral side, which is not seen in the control setting. We can see it both with treatment, but interestingly enough, we see it directly with the prevention. And basically, these animals who receive the biobridges at the time of the intervention do not develop lymphedema at all, whereas they do, obviously, in the control state. Here you can see it in a little more magnification. So, in summary, in this rat hind limb model, when we implant the biobridge at the time of lymph node excision, we do prevent development of lymphedema. We see development of a new lymphatic vasculature, and we see collaterals crossing the midline toward the contralateral normal vasculature. We do have a pending grant application, again, with the NCI to look at this application, and again, it will be a multi-center site trial in which we will be enrolling patients at the time of axillary lymphadenectomy for breast cancer to determine whether, in fact, we can prevent human lymphedema by a very simple surgical intervention that would perhaps add 5 or 10 minutes to the total surgical intervention at the time of axillary closure. This is the question that I get asked literally every day of my life. I think they'll never be over, but I'm happy to say that there are results and that we are transitioning from preclinical animal work successfully into the human arena, that there are options, I think, that exist today that didn't exist even a year ago, and that the future looks quite rosy as we try to asymptotically approach the right answers. So thank you very much for your attention.